So let's begin. Section 1, antihypertensive drugs, drugs that lower blood pressure. So diuretics, of course, elevate the rate of urination and water loss. Right? So when you flush out more water through the system, through the urine, you lower the total blood volume, so now the heart doesn't have to work as hard. There's less pressure in the system, so the systolic pressure is less, and there's going to be less resistance to blood flow because there's less volume pushing back. Does that make sense? So diastolic pressure goes down as well. So the thinking behind the diuretic drug is we can get more water from the bloodstream into the kidney tubules and urinate it out, then the total blood volume will be less, and so the heart doesn't have to work as hard. Systolic pressure drops, diastolic pressure drops. So there's several types of diuretic drugs, but just so you recall, 21% of the cardiac output actually goes to the kidneys. Kidneys are serving a very major role. And as you know, that through Bowman's capsule, a lot of things get filtered into the kidney tubules initially. But here's what's remarkable to me is that 99% of everything that gets filtered through Bowman's capsule into the kidney tubules, throughout its pathway through the kidney tubule, 99% of those things get reabsorbed back into the bloodstream. That only 1% of all the things that got filtered originally end up in the urine. So let's visit this quickly. So here's Bowman's capsule, and you have this high pressure gradient pushing things into the tubules. And then at certain points here, you see in the proximal part, you have sodium chloride being reabsorbed back into the bloodstream, potassium reabsorbed back into the bloodstream, water being reabsorbed back into the bloodstream, bicarbonate. Here, notice that glucose gets reabsorbed. You've been taught that. You've heard this said. In diabetes, glucose spills into the urine. Have you heard this phrase before? But that's not really what happens. Glucose is already in the kidney tubule, but it's at a level that all of it will get reabsorbed back into the bloodstream at certain points along the way, so that by the time urine is formed and excreted from the body, there is no glucose there. But if your blood glucose is super high and it pushes way more glucose into the kidney tubule than can be reabsorbed back into the body, then the extra glucose will appear in the urine, and that's a very serious loss of control in a diabetic state, as you know. Notice that amino acids get reabsorbed, sodium chloride again, potassium, water, notice magnesium. Here's where calcium gets reabsorbed. There's a calcium-sodium exchanger. We'll talk about why that's important. And then you see here the ascending thickened loop of the loop of Henle. And right here I want to just point this out to you. Diuretic drugs that are known as high-ceiling diuretic drugs, and this is an exam question for sure, work in the thickened ascending loop by inhibiting this particular sodium chloride pump. Notice that 25% of all the sodium chloride gets pumped back into the bloodstream right at that site. So if I can create a drug that will inhibit that particular pump, then I'm going to keep sodium chloride in the kidney tubule, am I not? And because sodium binds to water, it's going to hold water with it. Less water is going to get reabsorbed. It's going to pull water with it. And as it gets excreted in the urine, it's going to drag water with it. So by inhibiting that sodium chloride pump in the thickened ascending loop, that's known as a high-ceiling diuretic drug. There's also a low-ceiling diuretic drug, which you see in the more distal part of the convoluted tubule, where about 10 up to 15% maximum of the sodium chloride gets reabsorbed. So that's a low-ceiling diuretic that will inhibit the pumps in this area. Now I want to point something out that's really important. In the American Journal of Clinical Nutrition throughout history, a researcher named Robert McCarran has shown us on numerous occasions that people who have sodium-sensitive high blood pressure, if they simply will take additional calcium from supplements, that very often that alone will bring their blood pressure down. How does that work? There's a thing called the sodium-calcium exchanger. If I increase the amount of calcium that I put into my system, more of it gets into the kidney tubule, and my body will be so busy reabsorbing the calcium here and here and here that it'll leave the sodium in the kidney tubule. and I'll excrete more sodium, and with that more water as well. My blood volume will come down, even though I didn't change my sodium intake. I didn't go on to a diuretic drug. By increasing my calcium, I was able to manipulate what the sodium-calcium exchanger was doing, as it was busy pumping more calcium back into the bloodstream from the tubule. It was not able to pump the sodium back. And so the sodium stays in the kidney tubule with water, and then I urinate that out, my blood volume goes down, my blood pressure drops. So sometimes you're going to see in the lifestyle management, more calcium supplementation has been shown to help lower blood pressure. I want you to understand why it's able to do that, and we think that's the mechanism. Notice as we go further here into the distal convoluted tubule, the effect of aldosterone. We're going to come back and see this. Notice how aldosterone causes a secretion of potassium into the kidney tubule and reabsorption of sodium back into the bloodstream. So it raises blood pressure, and at the same time you're losing potassium. And a lot of diuretic drugs, what they do is not only do they reabsorb, keep sodium in the kidney tubule, but they allow more potassium to be excreted on an ongoing basis. So the person, as their potassium level drops in their bloodstream, what do we call that? Hypokalemia. And because the heart muscle is very sensitive to changes in potassium levels, if you go into hypokalemia or hyperkalemia, you get irritability and you start to have fibrillations, and the person can die of a sudden death heart attack easily from hypokalemia. And so one of the dangers of diuretic drugs, especially the early ones, is that the person was losing sodium and chloride and water and potassium. They'd go into hypokalemia, and they'd go into atrial fibrillation, and there's sudden death as one of the side effects. So they now, when a person goes on a high ceiling diuretic, they sometimes will give them what's known as a potassium-sparing diuretic to go with it, to sort of block some of these effects so potassium doesn't get secreted into the kidney tubule under the influence of higher aldosterone, which is often the case in a person with high blood pressure. We're going to see all of that. And now notice that down here in the collecting duct, the effect of antidiuretic hormone, which you have studied. So you know that if you're really nervous, you're about to give a performance, at Carnegie Hall for the first time. Right? You might be a bit nervous before you go on stage. It's like a solo production. You're going to be singing opera. You've never done it before. Standing room only. They really built you up. You're going, oh my God. You'd be a bit nervous. You probably would start to pee quite a bit before you went out there. Is that correct? If you drink a lot of coffee, you notice how there's more urination. You drink alcohol, there's more urination. Because when under those circumstances, you're inhibiting the release from the posterior pituitary of antidiuretic hormone. The other name for antidiuretic hormone is vasopressin, right? So when you inhibit vasopressin, then it doesn't reabsorb water from the collecting duct. There's a greater water volume. You urinate more often. So just so you see, this is where the effect of antidiuretic hormone comes into play. So a high ceiling diuretic is what we said. It's going to decrease a resorption of 25% of the sodium chloride at the thickened ascending loop. That's where those high ceiling diuretics work. And then the low ceiling diuretics are the thiazide drugs, and they're the most common ones. You're going to see a lot of patients over your lifetime. Their blood pressure is mild to moderately elevated. They're going to be on a drug that ends in thiazide. You're going to see there's all kinds of thiazide diuretic drugs. And they're a low ceiling diuretic drug. And if you give higher and higher doses, the effect actually plateaus, because that particular pump really is only responsible for 5, 10, maximum 15% of the sodium resorption, usually 5 to 10%. So the high ceiling loop diuretics can inhibit 25% of the sodium chloride, whereas the thiazide drugs, which are low ceiling, are inhibiting only about 5 to 10% in the distal convoluted tubule. And you can get potassium loss. So there are those potassium-sparing drugs like spironolactone. They decrease the amount of potassium secreted into the kidney tubule to prevent excess loss of potassium, otherwise occurs with diuretics. And remember, as I pointed out before, here's the aldosterone effect here, increasing potassium excretion. So we're going to come back and see this again when we talk about ACE inhibitors. Why is aldosterone even upregulated in the first place? I mean, why is my adrenal cortex secreting more aldosterone and raising my blood pressure. Why is it even doing that? Why is it that I have to be blocking this effect in certain cases to stop the extra excretion of potassium? We'll come back and see that. So the clinical applications then for diuretic drugs, of course, are to lower blood pressure. But they're also used in heart failure. Understand if the heart pump becomes weak, then fluids back up in the system, and when that happens, the fluids sort of diffuse into the interstitial space, into the lungs, and the person's basically drowning in their own fluid, swelling of their feet, of their hands. So if they give a diuretic and you're lowering the total water load on the body, makes it a bit easier on the heart. So they would give a diuretic drug also in heart failure. And also in liver cirrhosis, if the liver is actually stopping blood flow back and you're getting this increased blood volume sort of permeating into the interstitial space with swelling, they're going to try to lower the blood volume. So those are the things where you're principally going to see the use of a diuretic drug. What are the adverse side effects? See, if there were no adverse side effects, then these drugs would be great. The problem is that most people, not most, but many people who are on diuretic drugs have lassitude and fatigue. All of a sudden, their energy feels like they're zapped. This is what they'll complain to you about. Since I've been taking these drugs, I just don't have, I have no energy. I feel so weak and lazy, I can hardly function. And also hypovolemia. So there can be such a loss of blood volume that they can end up with orthostatic hypotension. They stand up quickly from a chair and they're a bit lightheaded because the blood volume is lower. But also muscle cramps. Once you start to interfere with electrolyte balance, so sodium, potassium, then muscles can become more irritable. They might come into your office and they have muscle cramps. Their calves are cramping up. Their hamstrings are cramping up. And you're saying, you need a massage. I think you got a subluxation at L5. Are you taking any medications? Yes, I'm on this particular thiazide drug. You know what? It may be creating an imbalance. You should get your blood work done to actually look at your blood levels of sodium, potassium, chloride, calcium, and then we'll know if that might be problematic for you. And it can also raise uric acid levels slightly and aggravate gout. So hyperuricemia is an occasional side effect from those drugs. And also it can mildly raise cholesterol levels. Mildly. I don't think this is the big downside to diuretic drugs. I just want you to be aware of it. And if potassium levels drop too low, of course, the person can have an arrhythmia. So where I've put these little asterisks, you see these? Because you're going to see a lot of drug side effects. Where there's an asterisk, it means I want you to know it. Where there's no asterisk, I don't expect you to remember it. It's something you can always go and look up later. But where there's an asterisk, these are important side effects that you as a practitioner should be on the lookout for. And also, one of the side effects can be metabolic acidosis, but it's a very uncommon side effect. I have a slide here for you just to review for you what metabolic acidosis is. We don't have to cover it now. I won't hold you responsible for that on the exam, but on your own time, you should review the fact that certain things can increase acidity in the body, especially diabetic conditions, excessive diarrhea in a child, any dehydration state, and can lead to these kinds of symptoms that can actually be life-threatening. So I just thought I'd review it, but taking diuretic drugs is usually not the cause of metabolic acidosis. These are some common diuretic drugs. The very first one ever made was the furosemide, also known as Lasix. It was the original one, but it had a lot of side effects, so they moved forward, and then eventually they created these thiazide drugs, and then later on they created these more high-ceiling diuretics for a person whose blood pressure is getting to the moderate or more severe range. So that's how diuretics work. And they're a very commonly prescribed drug. In fact, the discovery of furosemide back in the 60s was a huge breakthrough in modern medicine. It actually, after penicillin, furosemide was like the next really huge discovery, that we could lower blood pressure in these hypertensive people with medication. Until then, they really had no options available.